Good afternoon, everyone. I am Roslyn Holliday Moore, Deputy Director for Programs at the Office of Minority Health, the U.S. Department of Health and Human Services. I will serve as the moderator for this webinar on trauma and COVID-19, addressing mental health among racial and ethnic minority populations. This event is part of a broader recognition of National Minority Health Month and comes at a time when the impact of COVID-19 on racial and ethnic minority populations cannot be overstated. We are pleased to have a national audience of public health leaders, healthcare and mental health professionals, consumers, community members, and community and faith-based organizations in this important discussion on the mental health impact of COVID-19 and related opportunities for disrupting persistent patterns of mental health disparities in underserved communities. Before introducing our presenters, I would like to review a few housekeeping items. Next slide. We go to the next slide. We will have the first disclaimer here. This event is presented by the HHS Office of Minority Health. The opinions, findings, and conclusions expressed by speakers during this event are strictly their own and do not necessarily represent the opinion, views, or policies of the Office of the Assistant Secretary for Health, Office of Minority Health, and the Department of Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply endorsement. References to publications, news resource sources, and non-federal websites are provided solely for informational purposes and do not imply endorsement by the Office of the Assistant Secretary for Health or the Department of Health and Human Services. Both assume no responsibility for the factual accuracy of the content of the individual organization found at non-federal links. Next slide. This event is offering up to one Category 1 continuing education credit hour for professionals who are designated Certified Health Education Specialists or Master's Certified Health Education Specialists. If you hold either certification status and did not provide your ID number during registration, please submit your name and ID number to CHECR requests@minorityhealth.hhs.gov using the same email address used to register for the webinar. This information will also be in the chat for easy reference. Please note that these are the only continuing education units available for this unit. Next slide. The learning objectives of the Trauma and COVID-19 Addressing Mental Health Among Racial and Ethnic Minority Populations webinar are to discuss signs, symptoms, and impact of trauma, share strategies to maintain mental wellness, share mental health programs and resources focusing on racial and ethnic minority populations, and highlight current federal efforts addressing racism and health inequities. Next slide. All participants are muted upon entry. Please place any questions in the chat box on the right side of your screen, addressed to all panelists. I've been reminded more than once, please use all panelists to make sure that your question is fully viewed by all those that need to see, as we will not have a live Q&A. This event is being recorded. A recording of the event will be posted on the Office of Minority Health YouTube channel in the coming days for anyone who has missed the event or wants to revisit the content. The speakers' bios and resources will be posted on the Office of Minority Health website under the National Minority Mental Health information. Next slide. So at this point, I am honored to introduce two trusted colleagues who are widely recognized as national thought leaders on mental health, health disparities, and the promotion of health equity. Dr. Mary Roary is a public health epidemiologist who who is currently the Director of the Office of Behavioral Health Equity at the Substance Abuse and Mental Health Services Administration and the U.S. Department of Health and Human Services. She is also an adjunct professor at the Catholic University of America. She has worked across government, academia, and the private institution. Dr. Roary leaves a legacy of work from previous appointments at the National Institutes of Health in areas of health promotion, disease prevention, environmental influences, health disparities, and child health. Dr. Roary previously served as a data lead for the U.S. Department of Health and Human Services Office of Minority Health Committees on the Patient Protection and Affordable Care Act, Healthy People 2020, and Environmental Justice. Next slide. Our second speaker, Dr. Howard Stevenson, is the Constance Clayton Professor of Urban Education, Professor of Africana Studies, Human Development and Quantitative Methods Division, Graduate School of Education at the University of Pennsylvania. He is Director of the Racial Empowerment Collaborative, which promotes racial literacy in education, health, and community institutions, and the former co-director of Forward Promise, which funds community-based organizations serving health needs of boys and young men of color. Dr. Stevenson's research focuses on helping children and adults assert themselves during face-to-face microaggressions. Key to his racial healing work is the use of culture to reduce in-the-moment threat reactions, increase access to memory, physical mobility, and voice, and to prevent long-term health deterrent. He is nationally recognized as a clinical psychologist and researcher on negotiating racial conflicts and has summarized his work in the publication Promoting Racial Literacy in Schools, Differences That Make a Difference. With that, I would like to begin our presentations and ask you to welcome our first speaker, Dr. Mary Roary. Mary, the floor is yours.
Thank you. Good afternoon, all. Massive thanks to all of you for showing up and to the Office of Minority Health, OASH, for sponsoring this timely National Minority Mental Health Awareness virtual webinar. You all are in the right place at the right time because the time is now. Forget about the awkwardness, forget about the shame, forget about the stigma and or stereotyping of trauma. Trauma is real for all of us, especially for our under-resourced populations. Until we confront this head on, the problem will not go away. But if we continue to work this trauma away, then together we'll get there together. Next slide, please. I am going to go over SAMHSA's mission. You may know it, but it's a good refresher. It just sounds good saying it. I'm also going to tell you a little bit about the Office of Behavioral Health Equity, passionately known as OBE. We're going to share some SAMHSA data, recommendations, and resources, and I will be around for Q&A. Next slide, please. SAMHSA, the Substance Abuse Mental Health Service Administration, is the agency within HHS, and we lead public health efforts to advance behavioral health for the nation. Our mission is to reduce the impact of behavioral health across America. Next slide, please. We have 5 top priority areas, and they include combating the opiate crisis, addressing serious mental illness, advancing prevention, treatment, and recovery, improving data collection, my apologies, data collection, and strengthening the health practitioner training education. And it won't stop. I apologize. Next slide, please.
Call from Reverend Ph.D.
Now, the vision of the Office of Behavioral Health Equity is for minorities and disadvantaged communities across the country to achieve behavioral health equity. OBE's mission is to reduce disparities in behavioral health by improving access to quality services and supports that allow folks to thrive and grow in healthy communities. Our call to action is to continue to work towards eliminating and reducing mental illness morbidity, which is not, no doubt, been carried out and carried around for some time for most of us. Overlay this with COVID-19, the ongoing and nonstop civil unrest, economic, political, cultural, stigma. What will they think of me now? Or will they even believe me now? It has to stop now. We will hear why now from the great work from Dr. Howard Stevenson. And there is also a great paper out by Jarrell Excel that goes into granular details about why we have to do something right now. It's titled Intersectional Trauma, COVID-19, the Psychosocial Contract, and the American Racialized Public Health Lineage. It's in Traumatology. There's also some great work from Dr. Ruth Shim from Psychiatry Online entitled COVID-19, Structural Racism and the Mental Health Inequities, Policy Implications for an Emerging Syndemic. Okay, so now we have to do something right now. There's also some recent work from the Center for Disease Control. It's a study that shows that due to the implications associated with COVID-19, participants report increases in symptoms of anxiety or depression, increase in substance use, heightened stress response, and some report having serious thoughts of suicide in the past 30 days. National Institute of Mental Health estimates that there are more racial minority populations seeking culturally respectful mental health and outback health care. Next slide, please. Now, data. Data, just like location, 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 you must have data, data, and some more data. We must have the evidence to support our claims. It is so nice to do the right thing, but it's even more powerful when you have both reliable and valid data to support it was the right thing to do. But before we jump into this, you want to say, so the data. The data will drive the policy, and the policy will drive increase in needed funding that will drive sustainable change on the ground. If you remember nothing else from today, please don't forget about the impact of the data. Again, nice to say you have the data and that it made a difference. It's even more powerful when you have collected, tracked, cleaned, analyzed, published, and disseminated the data and its findings and next steps, also passionately known as a call to action, in acceptable and accessible formats for all to understand, from the affected populations to the White House. Now, trauma, COVID-19, and ongoing civil unrest and racism. Let's take a look at some of SAMHSA's 2019 data. It's called the NISTA, but it stands for the National Survey on Drug Use and Health, which is one of SAMHSA's premier data tools. Next slide, please. Here you will see mental illness and substance use disorder in America in 2019. Now, bear with me. I'm painting a picture and I'm going somewhere with this. So, among those with a substance use disorder in 2019, about 7.4 million struggled with illicit drug use, about 14 million struggled with alcohol use, about 2 million struggled with illicit drug use. If you look on the other side, among those with mental illnesses, you're looking at 13 million had a serious mental illness in 2019. If you combine both of those, so people ages 18 and older had both a substance use disorder and mental illness, you're looking at almost 10 million people. So in 2019, 61 million Americans had a mental illness and substance use disorder, and this was an increase over 6% almost in 2018, composed entirely of increases in mental illness. Now, imagine what the data looks like in 2021 and how this is even more devastating for our under-resourced populations. Next slide, please. Again, data from 2019 shows us the disparities of treatment gaps for substance use disorders, any mental illness, serious mental illness, major depressive episodes, and can get even worse if you have co-occurring any mental illness and a substance use disorder, and you are African American, and you don't have access to equitable care, and you are afraid to share your trauma, your story, because of the stigma, and you have a job that increases your risk for COVID-19, and you may be a young Black man who has to fear on a daily basis police brutality. Let's look at the data. The data shares that in 2019, for African Americans not receiving any treatment for substance use disorder, age group 12 and over, 12 and older, 90% didn't receive any treatment. If you compare it to the US population, ages 18 and older, 56, let's call it 57%. Well, compare that. It's 70% for no treatment if you're African American and you have any mental illness. Next slide, please. Unfortunately, this picture looks about the same for our Hispanic counterparts. Again, faced with the same scenarios as African Americans. Now, overlay this with language barriers, not having an interpreter, not having things available to you in your own or preferred language. The bottom line is that African Americans and Hispanics in 2019 are not receiving the treatment that is needed. I'm sure the picture is much the same today. And this treatment gap ranges from 42% to almost 90%. Here again, the data shows that substance use disorder for age groups 12 and older for the Hispanic community is about 90%, no treatment. If we look over at co-occurring at any mental illness and substance use disorder in the age group of 18 and older, 93% not receiving any type of treatment. This is unacceptable. Next slide, please. As we look here, there's some recent data on BIPOC communities for the rate of COVID-19 by cases, hospitalization, death by rate and ethnicity. And because of the two scenarios that I just described, I want you to go with me again, overlay this with living in crowded conditions, as well as perhaps working in the same conditions, close physical contact, in close space. No matter which row of data you look at, the rates are unacceptably high for BIPOC communities of color. It's simply unacceptable. Next slide, please. Now, what can we do about it? Well, we can continue to increase awareness that trauma, COVID-19, and racism and the ongoing civil unrest is real. And it is an exceptional problem for people of color already on top of their other daily disparities that they already have to deal with. We can increase the use of class, which are the culturally and linguistically appropriate service standards. These national class standards are intended to advance health equity, improve quality, and help eliminate healthcare disparities by establishing a blueprint for health and healthcare organizations. There's also the behavioral health class, behavioral health guide, which helps behavioral health professionals deliver culturally and linguistically appropriate behavioral health services, which was developed by our very own Office of Minority Health, OHASH, in collaboration with SAMHSA. And it's an implementation guide. We can also find creative ways to increase the diversity of behavioral workforce. We can partner and collaborate with all the resources that HHS and others fund to support community-based organizations, like the Resource Technology Transfer Centers that you see here on this screen. There is a rich opportunity to make sure that the TTCs are addressing trauma at the systemic, community, family, and individual level. We're also working with the regional administrators and the assistant regional administrators. And there's a plethora of samples of trauma resources for the individuals, families, and communities. And finally, we need to get help for ourselves and encourage the people that we live with, work with, play with, and pray with that it's okay to talk about the bad stuff. Even more okay and powerful to get help for it so that they can become better people, moms, dads, friends, leaders, Next slide, please. Here's just another snapshot of the TTCs. They are located across the country. They target African Americans, American Indians, Alaska Native, Hispanic, and Latinos, and they're available to help to make a difference, to also offset what we all are trying to do collectively. Next slide, please. Okay, and so here's some recommendations. They're global. So we can continue to conduct assessments to understand the needs of persons from diverse racial and ethnic or under-resourced populations. We can remember that data, yes, data, to inform the work in supporting those who need services. We can also continue to partner with community organizations. More research clearly has to be done on the intersectionality of trauma, COVID-19, and racism. And so, yep, there's some other recommendations and things we can do to increase the awareness that trauma and BIPOC communities do exist and is a major threat to the impacted communities, not just bodily injuries, not just property destruction and so forth, but certain mental illnesses, increased despair and hopelessness, and can spark and or increase substance use disorder. The time is now. And again, forget about the awkwardness, the stigma, and the stereotyping. The time is now. Again, our call to action is to stop the trauma before it happens. Prepare for the next pandemic now. Say no to racism. We have to act now because it's bigger than us. We have to help to eliminate trauma in under-resourced populations today. We must demand that our country support policies that support trauma-informed strategies, protocols, and or approaches with a prevention, treatment, recovery, and relapse and healthcare lens, which assumes that an individual is more likely to have a history of trauma and then advocate that it be applied to all so we don't miss anyone. There is no health without behavioral health. Next slide, please. Now, if you want to reach me, you can. There's no excuse. I'm here. I don't have all the answers, but together we can get there together. I will point you in the direction of the resources that you need to do what you need to do effectively in this field. Next slide, please. I would like to turn things over to the very dynamic and capable hands of Dr. Howard Stevenson. You certainly don't want to take a break. You certainly don't want to miss this. So please give him your undivided attention as he truly speaks to the why. Dr. Stevenson.
Thank you, Dr. Roary, and it's a pleasure to be on the panel with you and with Roslyn Moore and the OMH team. I am very excited to talk briefly about some of the work that we are doing and trying to just in some ways make a statement about the importance of engaging racial disparities from the lens of racial literacy. If you think about what's been happening, and Dr. Roy has mentioned this, is that the notion of hate has been increasing around racism and colonialism for over a decade. And in some respects, we continue to focus on disparities from a lens of amnesia, where we have known for over a century that when a catastrophe happens, it's going to filter its way down. And while for many people, the notion of a rising tide raises all boats, there are communities that do not have boats. And in many respects, the forgetfulness of how in our past, those with less resources are going to pay the penalty and brunt should be included in all of our trainings, whether it's medicine, whether it's psychology, social sciences. To predict racial disparities brings a different lens than to be surprised every time these moments happen. We know that racial hate has crept into our schooling systems, and studies have defined, even in workspaces, that people can report greater incidence of hate crimes and hate violence. But these professionals also report being overwhelmed as to what to do, right? The increased call for anti-racism training is also accompanied by the increased call to fight any sort of awareness of the history of racism and colonialism in this country. So as many ways we see an increase, as there are increases in social just action, there is also an opposite and equal increase in social unjust reactions. And so the question of how do we include these dynamics back and forth in our training of everybody, not just health professionals in the world. It's also a truism that the way that we think about the importance of engaging racial disparities from a systemic lens is essential, right? Not to negate that, but we also cannot forget the impact on health outcomes of interpersonal stress. That the proximal is just as important as the distal impacts of systemic racism. And this definition by Shelley Harrell out of Pepperdine is wonderful for years to define racism and the race-related transactions of oppression between individuals, but also groups and also environment, right? And that all of these things affect not only our identities, our individual well-being, but our collective, our community, our village resources. And to threaten those experiences means that it's affect who we are in relationship to. And so the notion of racism-related stress is not simply an individualistic notion, it's a communal notion. And so our research as well as our interventions must appreciate that communal nature of the threat. We also know from what Dr. Roy has already mentioned that this stress and trauma is linked to dehumanizing climates, to the poor quality of educator relationships with students who are different from them. And we've known even as young as preschool, the dynamics of racial oppression and distortion and stereotype play a role for little 3 and 4 and 5-year-olds of color across the United States. The notion that these disparities persist across generations is not lost on anyone. And I would just simply say, as much as these things affect the context of our society, we cannot forget blood pressure, we cannot forget sleep quality, and we cannot forget how we are breathing from one moment to the next. And so as much as legal strategies are important in a society that believes in law and order, where we can question whether that actually has been applied over the last several years, these legal strategies will not address emotional trauma from racism and colonialism. And so we must have opportunities and interventions that get to the proximal. A focus on race that is mostly around biological categorical differences that does not consider the racial, which is the daily lived interpersonal experiences, is a woeful agenda. While we have many studies that acknowledge the impact of stress on health and breathing, we cannot neglect that there are certain types of stressors that are particularly racial in the lives of some people, but not in others. And not to account for that extra allostatic load is also to negate the lived experiences and narratives of people who are different. In our work, we have pushed the notion that if we can see stress and its impact on the body, mind, heart, and soul, we can manage it. We can do something about it. The work in so many indigenous communities and the work that my colleagues and I have been doing at the Forward Promise have acknowledged that unless we appreciate the historical benefits of cultural approaches to dealing with stress and trauma, we are missing a great big advantage. And so the notion of socialization, of racial, cultural socialization that has gone across the centuries, across generations, to prepare young people for the future of a world that might not appreciate their humanity is also very important. And the question that still remains, can culturally responsive practices show us a different way of how to address the notions of racial and colonialism stress? So we need more than the legal, right? We've got to get proximal in our interventions. And so when we think about racial moments, not to negate the systemic, but the encounters that are face to face, we find that most people are overwhelmed. They still don't know what to do in less than 2 minutes. Some of the worst outcomes that we might see happening to young people or adults of color can happen in less than 2 minutes. You could argue that even 2 minutes is a very long period of time. You know, I've got to be able to make healthy choices and decisions thinking about the humanity of the other in much less than 2 minutes. But the fundamental reality is we know that these encounters mean that we get overtaxed in regulating not just our feelings, not just our thoughts, but our physical reactions, our bodily reactions, and all of that affects our voice. So a lot of the work that we've been doing is how do we help to navigate the face-to-face? Where does the competency come in to realize that in whatever profession I'm in, how do I negotiate my sense of overwhelm when I'm in front of a 12-year-old who I would, out of fear, assume that they are much older than they really are, much dangerous than they really are, much larger than they really are, and in those moments make the worst decisions. So we are interested in not just the systemic, but the proximal and the face-to-face. The work of racial socialization over the years has got a strong following of research to support it as a strategy to protect the identity, to protect the emotional well-being, to protect the physical health of Black and brown and white children as well, to see the world much larger than themselves, but that includes them. The what of racial socialization is about what information do we need to know? What strategies to prepare? The how is, how do we go about delivering the content? You know, most of us believe it's just parents that prepare children, but children also prepare parents. It's a bi-directional, communal directional, right? It expands beyond a dyadic or individualistic notion to share our histories and our knowledge. And the who, frankly, in a safe society or a society that understands the different diversity of experiences, you would expect you could leave home and go to school and still find a similar supportive humanity message about your difference. And you could leave school and go to the sports team and go to the online and still find affirmation of your difference. And that would be an antidote, part of the antidote to racial disparities. Why should some families feel compelled to give the talk or the talks, as it were? It's because they've got to help affirm the humanity that society has tried to take out, to protect them from the psychological as well as the physical harm, to redirect any self-destructive thinking that comes from swallowing the Kool-Aid of these negative narratives, and to connect them to thriving relationships and communities that understand who they are and don't have to second guess. If you look at the research on families that talk directly to their kids about race, or that children say, we've gotten some strategies, as we've seen in many of the cultural indigenous practices of providers and community-based organizations that take this stuff seriously, that it has impact on how preschoolers are cognitively and behaviorally competent. It has impact on academic achievement and engagement in very different communities of color. We also know in interventions that have taken cultural responsivity as central to how they not only target communities of color, but identify measures that reflect the lived experiences of those communities, of those children. In one study where we have used the court, the basketball court, as the site for managing stress, for teaching culturally responsive skills for young people, with the idea if they can overcome the face-to-face, in the moment stress that happens on a court, that can generalize to the classroom, that can generalize to the street corner. And in the same way, we have healing community activists like barbershops and beauty salons of folks who take their job seriously, who can also be taught to deliver these kinds of literacy services to young men and women with the same results of positive health outcomes. The theory behind this notion is that the more that young people get a perspective about who they are from a humanity, from a pro-humanity stance, is that when they're confronted by hatred, instead of folding or swallowing the Kool-Aid, their stress levels are reduced. And instead of avoiding, they find the voice, the courage, the spirit to speak to these moments and not walk away feeling like it was they who were the problem. And in a sense, in this time of hate, we need the courage, we need the skills that are necessary. So we learned a lot about how some families were very direct about talking about these issues to worry about in society, and some were a little bit vague, right? You know, I used to joke, my father would say, you know, if you lay down with dogs, you're going to get up with fleas. And that was supposed to be the civil rights message about how you manage hate. But the reality is that we know now we can be much more explicit, not only about what to prepare young people for and adults as well in an increasingly hostile environment, but also in the space of seconds and moments, how to feel good about who you are and to protect your sense of humanity. Three skills that we think about in a concept we call racial literacy is the ability to read, recast, and resolve racially stressful encounters. Reading, recasting, and resolving. Reading is about, do I see the racial elephant? Do I see the colonialistic elephant in the room, in the courtroom, in the emergency room, in the back rooms, right? Because some of us don't even know when a racial moment is happening, and that's going to contribute to a racial disparity. Can I see not only the racial elephant, can I interpret accurately what meanings of the actions that are occurring in these social moments, right? In these written texts, in these social media communications. Reading is fundamental to racial literacy. Recasting is about noticing that not only do I get stressed, I may get so stressed, say on a scale of 1 to 10, overwhelmed by the hate that is confronting me at an 8, 9, and 10. And when that happens, our brains and our bodies can go on lockdown. We can freeze, we can run, we can fight in those threat moments and at 8, 9, or 10. And recasting is about, how do I bring my 8, 9, and 10 down to a 5, 6, or 7? What strategies has my community taught me? What skill sets do I have to realize that this narrative about me, these experiences that are coming my way from a perspective of hate, do not have to define me? And so we have used a mindfulness strategy, not unlike other indigenous practices, where you take pause to calculate, locate, communicate, breathe, and exhale in the moment of the hate. Calculate is, to what degree do I notice what I'm feeling? And on a scale of 1 to 10, how intense? Locate is, where in my body do I feel the stress? Communicate is, what am I saying to myself? And who am I seeing? What images are coming to my mind while I'm going through the hate? And then breathing and exhaling to bring in oxygen. Because when my brain is on lockdown and I can't see to my left and right because I'm thinking only of that in front of me, I'm not a good decision maker. I might not have all the information, whether I'm a police officer, or a teacher, or a parent. I need to have all the information. Breathing in and exhaling allows information, oxygen to my brain, opens up peripheral vision and hearing, which means we appreciate the body, the thoughts, and the emotions. Calculate would be, let's say someone calls me a name or a slur and it bothers me to know, and I'm angry at a 9 and I'm sad at a 7 because this is somebody I never thought would call me that. Calculate. Locate is, where in my body do I feel it? I feel it angry at a 9 on the back of my neck. I'm so angry. And 7 in the pit of my gut because I felt like betrayal, that I would be treated this way by somebody I thought I knew. And communicate is around, what self-talk? What did I say to myself? How dare they? And what images came to mind? For some of us, it might be a grandmother, it might be a soul that told me the last time I was mistreated that I could still hold on. Calculate, locate, communicate is a recasting strategy. How do I look at the impossible hate moment, but turn it into a potential for change? Finally, resolving is, do I make a socially just decision that's not an underreaction or an overreaction? Underreaction is where I pretty much pretend that this thing that happened to me didn't really bother me, but it really did bother me, and it stays with me for decades. And overreaction is when I curse everybody out. And that includes the cat and the dog, and they had nothing to do with the situation. Resolving is not solving racism, but it's resolving the stress and trauma within me. The commitment to realize that if I don't take care of this now, it's going to come back later, not just for me, but for the ones who are in my life, who I love and who I care about. Reading, recasting, resolving racially stressful encounters. That's just a take home. We've got to address systemic racism, but we cannot forget the proximal, interpersonal racism and trauma, because it impairs our perceptions, because it touches our bodies, our hearts, our minds, and our souls. And that's going to impair our perceptions, our decision-making, our behaviors, and our relationships. To be threatened by these racial and colonialistic encounters is human. Right? There's nothing non-human about it. Avoiding these threatful feelings is also human, but it's unprofessional if we don't address it. It's unethical. It will lead to unethical behavior, and mostly it will leave us incompetent. We should not be wondering why there are racial disparities in 2021, not for the next pandemic. We can predict it, and how come we are not prepared? Racial stress is observable and resolvable, but only if we face it. Courage is not just solving the problems, it's actually admitting that we are part of the problem because we know what's coming next. And racial literacy is not about blame, it's about accountability. And that means we can be prepared. As young as 5th grade, 4th grade, we can be prepared for the hate that is right around the corner. I'm going to end. I think of a quote, one by Frantz Fanon: I find myself suddenly in the world, and I recognize I have one right alone, that of demanding human behavior from the other, one duty alone, that of not renouncing my freedom through my choices. If we can prepare young people for a world we hope will change, but if it doesn't, they can still be able to not renounce their freedom through their choices. And Peculiar Arrogance by Malefa Santi. I think of the climate that we're in now, the arrogance of not knowing what it is that they do not know, yet they speak as if they know what all of us need to know, right? We are seeing folks lying right in front of us. And I'm reminded finally of Frederick Douglass, who says, you know, we are living pretty much in a time of folks, of men who profess to favor freedom, yet depreciate agitation. There are men who want crops without plowing up the ground. They want rain without thunder and lightning. If we're going to manage these disparities, we got to tell the truth about our work and about what our children and our families and our communities are going through. Thank you very much.
So with that, I want to thank Dr. Roary and Dr. Stevenson for what I am branding as a very inspirational moment. Talk about lunch and learn. This was that. Thank you again for sharing both words of wisdom, but also words that encourage us for action. And as I look at the chat, you have many questions that have been rolling your direction from across the country, but I'm going to reframe one to launch us off. And actually, Dr. Stevenson, I just wrote it down from your slide. And it was, how come we are not prepared? I thought that was really a profound question. And it made me pause. Because as we sit in a context that's focused on equity as both a goal and an outcome, to have you raise a question, how come we're not prepared for action, leads me to this first frame. For both you and Dr. Roary, would you be able to give our audience one suggestion for those who are new to the work or who have been in it for a long time? How do we start in a way that's meaningful? How do we move the needle from health disparities to health equity so that we can become prepared? So Dr. Roary, I'll start with you.
Well, my best advice is to never, ever, ever, ever give up. It's a tough job, but we're going to save one person at a time. Also, the ultimate goal for what you just asked us is that we're not having webinars, we're not having seminars. It's in a history book somewhere. I don't have a job. So that's when we will reach the equilibrium that we need to reach for the whole equity paradigm. I have no job. I have nothing else left to do except to reminisce on how it was and how we got here. So that's when we know that we have made it. And then for the people who are new and to the field, it's hard work, but it's so rewarding to know that you can gather up great minds, subject matter experts like Dr. Stevenson. Like I was moved. I just wanted to go like this after he finished giving his stuff. Just moved by the wealth of information and strategies that you can use in real time. That's why you make. When Office of Minority Health sends out an announcement that they have a lunch webinar, you better show up because you miss out if you don't. So that would be my answer. Thank you. Over to you, Dr. Stevenson.
Oh, thank you, Dr. Roy. And the question, it is, I think, kind of challenging to be a human and somehow get used to the notion that you've got to live in a world where people dehumanize you. It's not natural. We don't think every day when we wake up that we're not human. We have to be reminded. And unfortunately, none of us want to acquiesce or concede to the notion that there are people out there who wake up and think about our demise and think about how to dehumanize those who are different. We're talking about Black, brown, and poor white folks as well. And so you've got to say, do I understand that I can still keep and maintain my humanity, even as I hope for a world that will become humane, even though it's not there yet, and then commit to the daily practice of preparing and protecting our young people and ourselves, that world ain't here yet, but maybe one day. But until that day comes, I will prepare, I will commit, I will put in the time, and then not worry or worry less. In some of our work, we know that parents who actually believe they deliver the talk really well get less stressed because they feel like if I do it well, my kids got it. That means they could actually use it in the real world. It's when I'm not sure whether I did it right is where the stress and trauma still remain. So it's a great question and probably way more answers to it, but that's what I would say.
Well, thank you for that part. And I'm also going to open up the mic for my colleague, Lindsay, who's helping me with managing some of the questions. And we can use this more like a lightning round so that we can process as many of those that are coming from our audience as possible. So Lindsay, if you want to start with the first question, that would be great.
Hi, everyone. Good afternoon. So one of our first questions involves an individual who lost their job early on during the pandemic. This person has only received discouraging responses and feels disinclined to continue to look for a job. The question is, could this person be undergoing some sort of mental health trauma? And I guess in general, how do pandemics affect our mental health? How can we protect our mental health during pandemics? And how can we cope with stress and anxiety?
Dr. Stevenson, you're going to be up, but before you speak, I would say diet, exercise, loving yourself, forgiving yourself, praying, and trusting something bigger than yourself. Dr. Stevenson, you're the expert here.
I think one of the insidious and dangerous elements of white supremacy is lying. And unfortunately, we all have learned that it's hard to admit that we are struggling. And one thing we do to ourselves, we don't tell ourselves the truth about when we are in hurting or harmed in emotional ways. And I would say, yes, the trauma is there as a function as it would be for anyone who's experienced that kind of rejection, and that is ongoing. You're not sure if it's going to abate. And I would say, if we break our leg, we're more inclined to go ask for help. If something physical happens to us, we're less resistant. Still, there are those who are resistant, but there is a physical expression of how harm, and I would say if we apply that same notion to our hearts and minds, we would not only heal better, but we would also challenge the larger dehumanization notion of white supremacy, and that is to not tell the truth about yourself.
Thank you both for that. Lindsay, if you want to go with the next question.
Sure thing. So the next question, do you have treatment data gap information for Asian American and Native American groups?
I'm gonna take a deep breath. I'm gonna say that we're working on it. We can no longer use the excuse that the population sizes are too small. And so for more information, I encourage you to shoot me an email and I'll connect you to our Center for Behavioral Health Statistics and Quality to make sure I can get you the data that you need. So it does exist, but not a whole lot. Thank you.
And I would suggest that at www.forwardpromise.org, we have among our grantees from very diverse communities, including those that you've mentioned, that have given their frontline experience in a couple of reports on what it was like to try to maintain culturally responsive practices during the pandemic. And some of these grantees around the country have been leaders in integrating indigenous practices to address specifically racial and colonialism trauma, but also specifically during the pandemic. It's another way to look at how those communities see the problem as well as the solution as a sort of beginning set of steps.
Thank you for that. Lindsay, next question.
How would you explain that addressing trauma in minority populations is a social justice issue?
Can you repeat the question? Thank you.
Yes, how would you explain that addressing trauma in minority populations is a social justice issue?
You want to go for it, Dr. Roary?
Absolutely. Gonna give it to you, Dr. Stevenson.
Oh, wow. I like the way we play. It's really wonderful. I would say if you look at every community of color that has landed here or were brought here against their will, trauma was also an element from the very beginning. There's not a historical reference you can find without one's ancestors having to navigate the dehumanization of who they were by virtue of language, skin color, or difference. And so how do you define culture without trauma? How do you define culture without this dehumanization? At least placed upon you, not necessarily how you see yourselves. So it has always been a justice issue, but just look at history, I would say. And the question is, are we still maintaining those same strategies of dehumanization in our political, our educational, our justice and health systems? And I'd say the answer is yes.
That leads me to a question. I'm not sure if you can see it on your side, Lindsay, but I can see in my chat here where the focus is on mental health promotion and how we are understanding our current circumstances with the pandemic. So it says, how can mental disorders and substance abuse be prevented during the COVID-19 pandemic? What interventions are available? And along with that, I'm noticing a couple of questions about actual resources that could follow up around the mindfulness practices and the strategies that you were introducing, Dr. Stevenson. So if you want to build all that into one response for the two of you, that would be fine. But I really like the idea that as we're coming to the top of the hour here, that it will give us a chance to really think forward about possibilities and ways in which we can encourage people who are taking good care of themselves in that mental health promotion and prevention space.
So prevention is key. I'm going to let you have it, Dr. Stevenson, but I'll say prevention is key, and that we listed, both of us, a list of resources that you all can use and share and disseminate at the end of the presentation. I think it's also linked to our bios, but I will say definitely prevention is key. Let's prevent it before it happens. And also, I seen in the chat, some folks brought up faith-based organizations, great place, schools, everybody is responsible for this. But I think what I usually tell my students in counseling is the best counselor does what? Go get counseling. And so I'll say it to all of us, if any of us have ever experienced trauma at any point in our lives, go get help and then share the good news. And so it's definitely going to improve your overall quality of life. And as Dr. Stevenson has said, it will drop down your blood pressure, clear your mind, so you can focus on real issues. Dr. Stevenson, thank you.
Well, along with the lowering of the blood pressure, imagine if you think about, children walking into a world that's narratives about them that are not true, that if we prepare those children and ourselves, if you can imagine a child being less overwhelmed because they've seen this before and they realize this is not about them, it's about others who are trying to think of them in inhuman ways, that's why the blood pressure goes down. That's why if you look at the research on racism among teenagers and lower sleep quality, that if I have the skills to see this is not about me, this is about them distorting my story, I know my story, that's going to affect health outcomes in very direct ways. So imagine if you could actually add an hour of sleep over your teenage years that go into your young adult years, how much more present you could be at work, how much more facile you could be at school or on the ball field. And we've got to think of racial justice as related to my heart, into my body, into my concentration, into my voice, not just making the world a better place, but will I sleep better? Will my children sleep better? And our children, frankly, want us to sleep better so that we can be around longer to be there for them, if that makes any sense.
Well, I did hear that last part. It makes a lot of sense. And as I move to wrap up this session, I want to first of all thank both of you with heartfelt appreciation for the time that you've shared, the wisdom that you've offered, but also for the opportunity that we all have to move forward in a path of true healing. And so this notion of a webinar ending does not have to be true. This webinar could just be the start of a conversation that leads to something very impactful. So I invite everyone in the audience to please follow up, go on the Office of Minority Health's website. You will be able to connect directly to resources and information from Dr. Roary and Dr. Stevenson. I encourage you to follow up with them in their respective spaces, to stay connected to the Office of Minority Health, and most importantly, to take good care of yourselves as we move to the end of this time. Thank you again all, and I wish you a good afternoon.